Hi, everybody. It's Dr. Eric Balkavage. We're back for another episode of the Thyroid Answers Podcast, and this is another Q&A episode. Tara is back. She was with us the last time because we did the part one of the Q&A, and she's back because we only got 4 done. We're going to try and get more than 4 or 5 questions done this time, but we're also not going to rush through them. We want to make sure we get the questions answered, because if Tara's patients have these questions or somebody that Tara knows has these questions, or Tara has these questions, then somebody else has these questions, and we want to make sure we get the answers for them. So Tara, welcome back to the Thyroid Answers Podcast. I appreciate you coming back and keeping us going on this Q&A theme.
It is a pleasure, Eric, to be here again. Looking
Awesome.
forward to this conversation. We've got a lot of information.
We got long way to go. All right, so let's get going. Let's get right into it. Let's start with question 1 for the day.
Is there a link between chronic stress and the development of thyroid disorders? And if so, what stress reduction techniques are recommended?
So the easy answer for part 1 is yeah. And when we talk about stress, right, I think that's where we have to start to defining stressors. Stressors can be physical, chemical, emotional, microbial. It could be disordered breathing, disrupted sleep patterns. We typically think of stress as what goes on between the 6 inches, like emotions. But everything coming at us can either be a positive stressor or a negative stressor, and we're designed and accustomed to taking on some level of stress in all those different forms. And it's not that we're going to be devoid of stress, but the issue is how much can we manage, right? And you and I were just kind of talking about this a little bit before we started this, and that is that it's the load, right? And so with all the things we have to do, if we're internalizing all those things as threat, as like danger or stress or pain or something that's triggering this connotation like I'm under too much pressure, that's going to change our physiology. It should change our physiology, right? Because as soon as we overload the system, or our perception is that we're overloaded or threatened, there is a natural adaptive response, which is slow down general metabolism and ramp up the immune inflammatory response. So, and when we do that, that decreased conversion of T4, T3 is part of the normal process. And then we're going to wind up with what Dr. Kelly and I talk about in the book, a multisystem adaptive disorder, which it means that you should expect every other system in the body that's not critical to cell defense to start to have a problem. Like you should expect adrenal changes. You should expect sex hormone changes. You should expect reduced digestive capacity, because none of those things are top of the list. You should expect disrupted sleep patterns. And it's surprising to me sometimes, and I don't saying this to badmouth anybody, when clinicians say that, hey, my thyroid patients all have hormone problems. Well, of course they do. Of course they do. Right. And so they're putting everybody on hormone replacement therapy because their hormones are low. And I get it. They want their patient to feel good, and that's what they're trying to do. But the problem is we're trying to take somebody who's in excessive stress, have what we call allostatic regulation, and normalize their blood hormones or lab values as if they're in homeostasis when they're not. And we assume that if we just give them more testosterone, it's going to work the way we want it to. And sure, giving them those things may create a short-term benefit, but it's doing a couple problems. One, it doesn't take long for the body to adapt and say, whoa, I didn't want that stuff to begin with. Or 2, now I have to be able to deal with that hormone, right? I now need to be able to detoxify it, metabolize it, and I don't have those systems in place. So now it can become problematic. And then the third thing is that we artificially give somebody the boost, and then it starts to taper. Then we think we need to give them more, right? And the other thing that doesn't happen is that person loses the motivation to actually address the real issue to begin with. And so now they become a slave to another drug, another hormone, another medication, or another supplement. But so we've never really addressed the problem. If you as the clinician want to do that, I think that's fine. If that's what your client's looking for. And if you guys are in agreement that that's what's the best strategy for the patient, fantastic, I don't care. But in my perspective, I don't think that's necessarily doing what we call functional medicine, which is addressing the root causes of chronic health issues. The root causes usually don't require long-term use of hormones and supplements unless there's been some disease or dysfunction that we need to manage. So that being said, and getting back to the original question, like what are some great strategies for managing stress? And it would depend on the stress, but let's go with emotional, because I think that's maybe where you're going with it. Is I think there's a lot we talk about in the book. We got a chapter in the book on emotional fitness, and there's things like MAP method and NMDR and tapping and meditation and journaling and a whole bunch of things. What's the best one? I have no idea. I mean, I've got an Apollo Neuro device. I think I have some clients that love the Apollo Neuro device. I think it's a great tool. I have brain tap, and some patients have brain tap and they love it, and others don't like it, right? Some people like Apollo Neuro, some don't like it. Some like neurofeedback, some don't like it, right? Some do NMDR, and other people, it's way too much work. For some people, they love MAP method. For other people, they're like, that's too woo-woo for me. Like, everybody's got to find the tool. And I said this on a number of podcasts, but you got to find what's your thing. And like for me, as much as people may not like, get what you think about hunting, like I started archery shooting because for me, I had to quiet out the noise in my brain while I was trying to learn how to shoot a bow and be on target. Because you can't be thinking about a whole bunch of things because you're working about your breath. How's my timing? How's my alignment? All those things. And to me, that was a level of meditation, but it's short. You can't shoot your bow for hours on end at a time. And then I started doing archery hunting. And that's when I really realized, even though I was doing a lot of things right, I realized that sitting in the woods for 6, 8, 10 hours was difficult without social media, without reading something, without filling your brain with something. And I think that became how I reduced the emotional stress, because what I had to do in those hours of sitting by yourself in the woods is all of that noise becomes, you're aware of it, right? There's nothing to block it out. I'm not watching a TV show. I'm not watching a video or watching something else that kind of blocks that out. I think that's why we go on TikTok and Instagram and all these things, is because if we listen to everybody else's noise, we don't have to really listen to what's going on in our own brain, in our own mind. And for me, that was my meditation. That was the thing that really helped me manage my emotional stress, was forcing myself to sit in the woods. When I first started, it's like hour and a half. I'm like, I got to get out of here. I got stuff to do. And one day in cutting that short, I was like, if I can't sit here with myself and my own thoughts without getting stressed and anxious, I need to sit here for 6 or 8 or 10. I need to learn how to do that and be at peace with myself. I enjoy nature. There's so much you can see when you're not all in your head, and you're able to, all that stuff quiets down. You see the squirrels, you see nature. So it's less about the hunt for me, which to some degree is important because I eat all the stuff I hunt, but it's really more important to me about unplugging from all the stuff that distracts me from the internal conversation, allows me to hear the internal conversation and deal with that. Does that make sense? So whatever that is for you, if it's chess for you, if it's reading a book, if it's doing puzzles, if it's sitting in your sauna or hot tub, whatever it is. But I think for most people, if they really want to reduce the emotional stress, because emotional stress is really about your interpretation of your environment, not really what's coming at you. Do you understand what I'm saying? Like, Okay, somebody got a car,
Absolutely.
somebody smashed my car, right? I could be upset about it, and I could be mad, and I could be angry, right? And you could say, you could justify that. Or I could be like, were you hurt? Okay, I can get a new car. We can get it fixed. It's going to cost some money. It's not a big deal. What did I learn from that experience? Oh, Joe's a terrible driver. Probably not a good idea to loan your car to Joe next time. Let him get a rental car, right? But how can I use that, whatever that thing is, as a building block versus focused on the negatives of, oh my gosh, my car's destroyed. It's going to cost me so much money. And carrying that around.
Yes.
So I think whatever it takes for you to find your own way to deal with your emotional fitness is going to be unique to you. But what's your thoughts there?
Well, first, I think the question itself is very insightful, right? Because I can appreciate asking the question, is there a connection? But also, if there is a connection, is there something that I can do about it to reduce stress instead of what do I do about my thyroid because of it, right? Because again,
Right.
it's root cause medicine. This fires me up like almost more than anything else because I too, as somebody without a thyroid, I believe I want to feel as good as possible. I want everybody I know and work with to feel as good as possible, but we have to understand what's going on. So the question about chronic stress, as you stated, it could be emotional, physical, toxins, trauma, food. There's like so many different things. But the bottom line is, whatever it is, our perception, like you mentioned, is a crucial component because there's always going to be bad things that happen, right? Things that we don't want to happen. That's a unfortunately or fortunately, because like you said, there's a lot of things you can learn from it. But these things are unavoidable, right? So how we perceive the situation, right? And I do think it's normal, hate that word, but normal to feel bad sometimes or to have negative feelings about things. What I try to do and what I try to convey to all of my patients is we can feel the feelings that we're having, but then try to step back from it. And like I tell myself, I almost like do this and I'm like, I'm okay. Literally, like, I'm okay. Everything's okay. Whatever it seems is horrible at the moment, I'm okay, right? And right there, that thought, that message, I believe, and from everything I read, we can send new messages throughout our body, right? We can send new communication pathways, and that's going to have positive down, or it can have negative, but I'm hoping positive downstream effects with our cells in our body, with our hormones, with our microbiome, and everything is connected, right? So you said, as of course we've discussed before, the thyroid stress, everything is going to impact all of our hormones because things are not in isolation, right? And so when I have somebody come to me with low estrogen or low progesterone, I always want to understand why. And then what is their lifestyle like? And it may not be a sexy topic. It's one I talk about every day. And for me, it's what made the biggest difference in my life. It wasn't the thyroid hormone, right? Or any other hormones. It's what am I doing to manage the load?
Yeah.
Right. And so,
and I think the other thing we have to keep in mind, especially the patient, if you do have a lot of emotional stress and that's triggering a stress response, we should expect a reduced conversion of T4 to T3s. But the person might say, but why not just give the T3? Because if I'm having reduced conversion because of the stress, I just take the T3. Well, the T3 may temporarily make some symptoms better, but it may also increase the anxiousness and the anxiety, which then you think you need something else. So I think that becomes important. And I did have this conversation with somebody the other day who's a clinician, and we discussed this. And I said, okay, so if your patient had a fever, should they take something to suppress it? And as a functional practitioner, they said no. And I said, well, why not? They're like, well, because the fever that is the body's natural response is the fever. So if I suppress the fever, now it'll take them longer to get over the infection. I'm like, So the uncomfortable, not so good feeling they had caused by the fever, you don't feel you should change just to make the patient feel better because it's going to alter their ability to heal and repair. It's not addressing the root issue. She said, right, I would maybe give them something for the infection, but I wouldn't reduce the fever with a support. So then why were you doing it with the thyroid hormone?
That's a great point.
Right. And she was like, what do you mean? I'm like, well, if you're under the same philosophy that the body's creating changes based on the threat in the fever situation, the threat was in an organism and it got a fever, and you're saying you wouldn't alter the body's natural changes because you'd interfere. Why do you think if this decreased T4 to T3 conversion is the body's adaptive response, why do you think you need to interfere with that? Why wouldn't you do the same thing? Ask why it's going on and address that. And after a little bit, that physician came to the reality, like, you know what, I never really looked at it that way, because they were thinking broken physiology. Somehow the other stuff is adaptive, but what's going on with thyroid in their mind was always broken. And now hopefully they're seeing a different point of view. Like, okay, maybe this is adaptive. Maybe the change in sex hormones is adaptive. Maybe I don't need to necessarily give them something that their body's not naturally making. And maybe I need to address the root cause, which to me, if we can make that message and get that message to clinicians one at a time, or 100 at a time, I think that's going to do a lot more for our clients and a lot more for functional medicine. We're doing what functional medicine's supposed to be about. But let's go to the next one.
Okay. Can gut health influence thyroid function and disorders like Hashimoto's disease? How can I improve my gut health to support my thyroid?
So can gut health influence thyroid function and disorders like Hashimoto's? The answer is absolutely it can. There are direct lymph connections from gut to thyroid. So if there's stuff entering the lymph tissue, things called pathogen-associated molecular peptides, damage-associated molecular peptides, pieces of toxins or organisms getting into the lymph, they can get to the thyroid gland. Those damage-associated or pathogen-associated particles, when they hit the thyroid gland, they can initiate thyroiditis. Problems in the gut can affect conversion of T4 to T3. Problems in the gut can cause inflammation it affects systemic inflammation, and it upregulate the immune system and alter T4 to T3 conversion. So absolutely, gut health can influence thyroid function and be a trigger for thyroiditis and Hashimoto's. The second part was, how can I improve gut health to support my thyroid? Part of it is what we just talked about, like reduce the stress load, because when your brain is perceiving stress, threat, danger, there's a natural upregulation of the sympathetic nervous system and a natural downregulation of the parasympathetic nervous system. So for your GI tract to function well, you need more parasympathetic activity. You need to make stomach acid and bile and pancreatic enzymes, and you need to have healthy function and physiology. So if the brain is stressed, it changes our biome. If we have brain is stressed, we reduce our digestive capacity. If we change the biome and change our digestive capacity, it really doesn't matter what we eat. We're going to have digestive symptoms. We're going to have probably inflammation. We're going to have permeability issues. And then we're going to have more thyroid issues. And then it becomes a vicious cycle, because now as I have more downregulation of my thyroid physiology, I'm going to have more challenges with making the things that I need to do digestion and move my bowels, and that creates more dysbiosis, so it becomes a vicious cycle. So I'd say, number one, identify what's contributing to your stress load, whether it's emotional, disrupted sleep, too much alcohol, poor diet, and start addressing those. Even simpler than that, just improve what I call your fitness factors. Eat healthy whole food 85% of the time. Limit your amount of alcohol. Get quality sleep each night, or at least attempt to try and get a quality sleep. Breathe well. And it means at night, probably nose tape, mouth tape, so that you're breathing nasally, not orally. And then be aware of what's going on between the 6 inches of your ears on a regular basis to see if mindset and emotional fitness is part of the issue. And then lastly, increase your physical activity and exercise to what's possible, because physical activity plays a big role. If you do all those things and you still have GI related problems, then that's where I would really suggest working with a functional practitioner to find out how nutritional support might help you. And I would recommend that before you just start slapping stuff. Take that, I'll take that, I'll take this probiotic, that probiotic. You might create changes, but you may not address the real issue. So that would be my answers.
Yeah. And I call that throwing darts in the dark also, right? Because we don't know what's going to work. And usually somebody, if they're doing that, they're doing multiple different supplements at one time. So if they feel better, they don't know which one is contributing, but then they haven't addressed the root cause, right? And when I have this discussion with my patients about the gut connection to our whole body, I talk about how it's like this web, right? And it spreads everywhere in the body. And the thyroid, it is one of the things that will be impacted, but so is everything else in the body, right? And when you talked about those DAMPs and PAMPs and lipopolysaccharides getting through, that's something that I really want to raise awareness for, because it is a real thing. I do a lot of testing for that, and I see it all the time with these endotoxins getting through, and then we have so many symptoms, right? So if we just pound the body with thyroid medicine, it's not doing anything for the reason why it's having an issue to begin with. And if we don't address why the gut has more permeability, if that's the issue, right? And from my understanding of it, so many things can cause the lining of our gut to become more permeable. And that's a normal part, right? That it's supposed to be somewhat permeable. That's how it lets nutrients through, amino acids, vitamins, minerals, water, right? If we don't address that, like one poor night of sleep can cause the lining to become more permeable. One negative thought. I think about that when I have that stinking thinking, as we were talking about last week, that if I have these negative thoughts, do I need to have them? Right? Do I need to have these thoughts when it's going to have an impact downstream everywhere? If it's a problem I actually have to face and do something about, is this the time for me to do that? Or am I in this stinking thinking mindset where I'm not going to, like, a positive outcome isn't going to happen? So like you said, addressing the reason behind it, and then all of the things, the bottom of the matrix, the 5 modifiable lifestyle factors, all of those things can contribute positively to the gut. And then maybe we do need to do something further. There are lots of supplements and things that can be helpful, but if we're not doing the other things, I don't believe we're really going to have much benefit. And we can actually become more frustrated, maybe feel more negative, and then have more health stress. And health stress is a real thing. I experienced that for quite some time, thinking, like we talked about, get me optimized. Asking all of my practitioners, I need more. Some things I don't feel good, but I was doing really nothing for my health, the core fundamental principles like you talked about in your book and that I talk about every day, right? I wasn't sleeping. I had a horrible diet. I had such stress. I was over exercising, and I had like stressors around me. I was surrounded by a lot of toxic individuals and thinking, well, it's just a part of life. When I changed those things, when I started to work on what can I do to move my body, right? Like not run, well, sometimes running, I think, is great,
Right.
but not overdo it, but just gentle movements. Then all of these, they're going to have positive downstream effects throughout the whole body. And the gut is like front and center with our whole body.
And I'd say let's wrap that question up with this final thought, which is, if you're the person who's been to a lot of functional medicine practitioners and you've done a lot of gut protocols and they've worked temporarily and the symptoms come back, or you have chronic GI symptoms, that should be a big clue to you and your practitioner that the gut is the result, probably not the problem. And in most cases, I see a lot of those people, there's a lot of emotional stress, limbic windup, and their emotional fitness is not very good. And when they come to the realization that, wow, a lot of this is going on here, and I'm in a greater state of stress, what's today? Friday. But that's twice this week I've had patients that came to that aha moment this week that said, I don't think I'm managing my stress as well as I thought it was, right? We all perceive that we're managing our environment, all the stress really well, because it's just how I am. Every Tuesday is, every Wednesday, every Thursday, right? And we figure we always have it figured out, but and maybe not everybody's ready to hear that, hey, this is playing a big role in why this isn't getting well. But it's nice when somebody has that aha moment, and it's happened twice this week where people were like, I really think it's about how I'm dealing with all the stressors in my life. I'm like, good, because I agree. And I can't help you fix that until you're aware of it and willing to take that as a possible consideration. Now, we might still want to help digestion while you're going through the process, but we're not going to continue to try more food elimination, more this, more that, more this, when this is the thing we need to do. Let's not go on another crazy diet. Let's just focus on a whole food-based diet, right calories and macros, and you working on your emotional fitness. And that should help more significantly than round and round of antimicrobials and trying to do the 37th different dietary strategy. That's probably not what's going to fix it. All right. So let's go to the next one.
Okay. How does living in a house with mold influence the development of thyroid disorders like Hashimoto's disease?
Okay. So there's a lot of opinions on this, that mold is the problem for everybody. Like, it's mold. And there's people that this is all they do is identify mold and treat mold. And for them, through their bias, through their level of ignorance, this is everybody's problem. There are clinicians who think everything is parasites and everybody needs a parasitic cleanse, and parasites are the cause of everything. I think we have to be careful with that thinking. You could be in an environment that has mold. You could be breathing in mold spores, have mold issues. And in one person, it could be a significant issue. For somebody else, it may not be a significant issue. So if you're in an environment that does have a high concentration of mold and mold toxins, and especially if it's the more problematic molds, regardless of whether you feel good or you don't feel good, I think you should address it, right? Especially if it's a big deal, if it's Stachybotrys or one of those things. But it doesn't mean it's everybody's issue, and we have to be careful with that. So we always want to reduce the burden of toxins or potentially problematic organisms, but it doesn't necessarily mean it's everybody's cause of thyroiditis and Hashimoto's. However, in a large percentage of people, or I don't want to say a large, but in a percentage of people who are exposed to it, their immune systems have lost tolerance to those toxins. They have lost tolerance to those organisms. So we can do antibody testing and see they're making antibodies to those toxins, or they're making antibodies to the organism. And if that's the case, that likely is driving their immune and inflammatory response. And so we have to do whatever we can to reduce the exposure so that their immune system can calm down. That thyroiditis, that immune dysregulation, that alteration in thyroid physiology in those situations is not broken physiology. Again, it's adaptive physiology. And so in those situations, trying to force more thyroid hormone into a system that was down-regulating it to begin with is probably going to be problematic. So in that situation, we want to say, hey, if there's, and you and I probably do this the same, if somebody's got this tissue hypothyroidism pattern, we're trying to figure out what that is. And we're going to run through organisms, toxins, molds, emotional stressors. We're going to look at all those possible criteria and then say what it is. And if it looks like it's an issue, we need to address it. And there's different ways to test. I like the antibody test as kind of the definitive on whether it's pushing the immune system. There are urine toxicity tests, which I think are good follow-ups, but I don't like them as the initial test, because I can have a husband and a wife who live in an environment with mold. One's got chronic immune issues and thyroid issues and whatever, and the spouse, usually the man, doesn't have the same issues going on, right? And so if it was just mold, then we should be able, then they should both be ill at the same time, right? And if we do a urine test, maybe we do find that both have urine mycotoxins. But if it was just the presence of the uromycotoxins was the problem, then why is the spouse not sick and ill, right? So it must be more than that. And it's the immune reaction to those things. And then the other part of it is, depending on somebody's state and the health of their detoxification pathways, we could do a urine mycotoxin test and it might be clear, right? And we'd say, okay, there's nothing in the urine, so therefore the person doesn't have a reaction. But if they have tissue hypothyroidism and they have reduced detoxification function and they're holding on to lots of excess fat, those toxins might be stored in their tissue. They may not come out initially. And so looking at that test may not be the best thing in the initial. It might be the good thing later to say, hey, is the load or is the burden going down? But it may not be the great test, in my opinion, as a starting point. People might argue that, and that's okay. I don't know that I'm right, but that's just my bias.
I feel like I also have that bias, and it's there's so many clinical pearls with what you said, but when you described the husband and wife, that's my husband and me, right?
Yeah.
So live in the same house. I developed all these autoimmune conditions, including Hashimoto's and positive mold, right? And my husband is fine. So then it led me to do further testing, and I was reacting to almost everything, right? I like Cyrex Labs. I usually use them for the antibody testing. I am definitely a fan of looking for the immune system response. Somebody gets a test done. I've had numerous patients that brought me their tests of their home. That's, it's great that we found out that you have mold in your house, right? But what is your immune system doing? If you're peeing it out, it's not telling me what your immune system is doing. And that's what the question really has to do with, right? Is the body's response. So autoimmune response is a dysregulated immune system, not broken, right? I'm not broken. It's adapting, as you say, to all of the stressors that are around. So I think mold matters for sure, but was the mold why I got caught, somehow caught Hashimoto's? Of course not, right? I was reacting to everything. Literally, my test, almost everything was positive. And I lived in, this was a long time ago, I lived in this perpetual state of fear that everything was out to get me. And that is not a place I would ever want anybody to be in, or to say it's me, right? Yeah. And I did lots of other testing and lots of snags with detoxification. The more I learned about this, the more in this rabbit hole I went. I realized that that's a very empowering feeling, right? I was very empowered. No wonder I had all of these issues, these health issues, when somebody else in the same circumstances, right, wouldn't have them. There's so many different factors that come into play, right? And when I worked on detoxification pathways, when I worked on all the modifiable lifestyle factors, and then I did something about the mold, right? Because it still matters, but like you, it's not all about mold.
Right.
And I feel like there's a lot of, dare I say, I can be not confrontational. What is the word? Opinionated.
Yeah.
That's me. There's a lot of practitioners I feel that prey on individuals that are terrified of these kinds of things, and they make everything about one thing, and it's all about mold or parasites. I've had lots of people who have parasites, right? All different, not everybody, right? And there's if we create these blind protocols and lump everybody in them, I think that's doing a huge disservice.
Yeah. And I agree. And that's why it's got to be an individual process. As much as everybody wants to say, what's your thyroid protocol? I don't have one, right? Because I don't know what your issue is. I don't think your thyroid's broken. I don't think your thyroid physiology is broken. I think your thyroid physiology is an adaptive response. And so what we need to do is find out what your load is that we need to address. And then once we do that, you'd see improvement of thyroid physiology. I think I just did a thyroid Thursday maybe with somebody who, after, I think it's like 2 years, but 2 years ago, they were on 150 micrograms of T4, not feeling well. And we're at a 1 year anniversary of working together, and they're on no thyroid hormone anymore. Like, what did we do? The only thing we did with the thyroid physiology was continually recommend a dosage decrease while we worked on emotional fitness and gut physiology and diet and nutrition and exercise and sleep. And so in doing all of those things, somebody who was on a prescription of 150 micrograms per day was able to go to nothing, right? And so did they really need the thyroid medication ever at all? No, it was probably inappropriately prescribed, given not that the person was trying to be do the wrong thing for the patient. I believe that they were really trying to do the right thing. The person had the signs and symptoms. The person had subclinical hypothyroidism. Why not give them some and see how they do? Oh, they felt better, but now it's tapering. So let's give them a little bit more, and let's give a little bit more, and before you know it, within a couple of years, you're on 150 micrograms, which is more than your body would ever make. And you still don't feel well, right? So I think we shouldn't be doing those things. I do want to touch on one thing that you said, and I think it's an important thing to cycle back to, is that on the antibody testing, and especially the Cyrex testing, we do see this a lot, where somebody who's got some chronic immune issues going on, they have polyreactivity, which means you're making antibodies to almost everything. And for the listener, what this means, if you see like an immune panel and it's like, I make antibodies to everything, right? Like I had a food sensitivity done and I'm reacting to everything. There's only like 2 foods I can eat. You probably aren't reacting to everything. What you've made is some antibodies that are less specific to some one thing. Typically what your body does is you have immune cells that go out, they find the thing, they bring pieces of the thing or the problem back to the plasma cells, and the plasma cells are a type of B cell. Plasma cells then turn into a B cell and they produce antibodies, which are specific, or should be specific to something. The first antibodies that go out are typically like IgM antibodies. They're not quite as good. It's like the first version of the iPhone. It was good, but we can make a better version. And so after those IgM antibodies are made as part of the acute response, then we make an even better antibody. It's called the IgG antibody. But for some people, is that there's so much going on. And I think what happens is the immune system just puts out these kind of very general antibodies out into the system that can react to lots of different things. And that's a great protective response when you really aren't quite sure what the heck the thing is. But you can look at a panel like, and I did an autoimmune panel and I have antibodies to everything. Well, you probably don't, right? It's just you have this polyreactivity. And that can be frightening for somebody who does like a food sensitivity test and somebody's not explaining to them, like, you're probably not reactive to everything. This is probably polyreactivity. Your immune system is a bit stressed, and it's making non-specific or less specific antibodies that are like, yeah, I guess that's a problem. I'll react to that, bind to that. So I see that a lot with people when we're doing some tests. But when you see like the full panel, there's only two things I'm not reactive to. We typically look at polyreactivity in that case. And then if we do look at other types of antibodies panel, like Thyrox's array 10, 11, 12, 3 good tests. But if one of them's got polyreactivity, you almost got to be like, let's not run another one because it's going to be the same thing. And we're spending a good chunk of money on those tests. And that's the time to take a step back and say, we don't really need to run the other ones. You're going to have polyreactivity. We need to get your immune system kind of calm down first. And then we can make a decision. And in my opinion, a lot of times when we see that polyreactivity, my experience has been that the thing that probably triggered the immune response may no longer be there. And what the person is dealing with is the immune system that got turned on is having a hard time getting itself calmed down. Maybe because of limbic windup, maybe because of gut issues and decreased T regulatory control. But that's what I typically see. But anyway, we'll go on to another question.
Okay. How can I differentiate between symptoms of thyroid dysfunction and menopause? And what are functional medicine approaches to treatment?
The challenge is many of the symptoms are exactly the same.
Yes.
And so I've never experienced menopause myself. Okay. So you might have a better answer for this. However, it's my belief that going through the change, the swing, the symptoms that we experience aren't normal symptoms of menopause. I think as we go through the change, the symptoms people experience are the result of now seeing other issues and other challenges. Okay. So for some of them, maybe, what do you mean? There's a lot of women who make that hormonal change and transition without much signs and symptoms, right? They're like, I don't know, it's good. I didn't have a problem. No, I did good. So if they can do it without issue, but a lot of people have problems, who's the abnormal? Like, who's got the abnormal physiology, right? I don't know that whatever you believe in, but the intelligence that built the body decided, hey, we're going to start pulling the carpet out from these people, and we're going to make them feel like shit as they're going through this change in life. I don't think that's the case. And so when you have a lot of perimenopausal and menopausal symptoms, I think it's a time to step back and say, okay, what else is going on here? Do I have something driving the cell stress response? Do I have potentially reduced T4 to T3 conversion? Do I have some issues that are impacting my mitochondrial function? You could, if you had good estrogen levels, but you had some reduced T4 to T3 conversion, that higher estrogen level may compensate, because as you know, estrogen really drives mitochondrial function. But if I have reduced T4 to T3 conversion, and maybe it's not too severe, but it's a mild reduction, and I lose my estrogen, now I may be more aware that, whoa, I don't make as much energy. I don't feel as good. My blood glucose regulation's off. So I don't think and I'll let you comment here, but I don't think these are the normal symptoms of menopause or perimenopause. I think these are common symptoms of menopause or perimenopause. And then we need to just ask the better question, which is, why is this occurring in this person? Because if you don't, then what happens is somebody just says, you have these symptoms because your hormones are lower and that you're used to higher hormones like you had in your 20s and 30s. And the answer is just to give you bioidentical hormones to replace those levels. Could you feel better? Absolutely, you could feel better. Is it actually fixing the problem? No, because I don't think a 65-year-old female or a 55-year-old female who's in menopause was designed to have the sex hormones of a 25-year-old. So I had this discussion with another clinician who said, well, what's wrong with giving a woman the estrogen or progesterone if it makes it feel better, or testosterone? Nothing. If that's the goal, if the goal is just to temporarily make sure she feels better, and she doesn't care if she wants to take hormone replacement the rest of her life, and you're supporting all the detoxification pathways, and that's good enough, I don't care. But I don't think the intelligence that built the body decided we're just not going to have men make appropriate hormones, and we're not going to have women make appropriate hormones as they get older. I just don't think that makes sense.
Well, you brought up something very important, right? And as somebody, you might not know what perimenopause and menopause feel like, but I do.
Mm-hmm.
Not menopause yet, not that I know of. Still perimenopause, and I was going through it horrifically. Like my whole life got turned upside down, and it was all around the same time with me with being diagnosed with hypothyroidism. Everything was kind of, I didn't know I was perimenopausal, because it's not like you look at a calendar and you're like, that's the day. It's more thinking back like, oh, wait a second, this makes sense now,
Mm-hmm.
right? And so I had such horrific symptoms and I had no idea. And I worked in women's health before I started my own practice. And I prescribe medications all the time, right? I'm not against medications or hormones if they're appropriate. I'm a fan of looking at the whole picture, casting a wider net. Do we need a label, right? A lot of individuals are, give me the diagnosis. That way I know what's wrong with me.
Mm-hmm.
And okay, so you have this diagnosis, then that's the end of the story in conventional medicine. Here's your script. What I try to teach individuals is that's the beginning of the story. Why do you have hypothyroidism or low estrogen or whatever is going on, right? And so I do a lot of testing. I'm a fan of more functional lab testing, because if I'm just looking at blood, I know it's the gold standard for a lot of things, but I don't feel like it's giving enough of the picture. And it's not saying what the receptors are doing, like what the body is doing with the hormone. So you can fill the bloodstream with it and the blood level looks normal, right? Or optimal, like some people would say, but it doesn't mean the person's going to feel better, right? And I want to know, what kind of predisposition do they have? As somebody with lots of these horrific genes that those practitioners, specialists that I saw said, I'm screwed basically. I can't escape my shit genes, is what they told me, literally. And they were wrong, right? It's a piece of the puzzle, but I like to know that piece if possible, right? But as a clinician, I'm going to work with that individual. And if they're dead set, please, I want to try these hormones as long as it's safe. I'm not against doing that, but education is such a big part of it, right? Because if we take the hormones, but we're not doing anything else, right? Are we going to feel better and be on the best health trajectory? I would say no. And we could potentially be on a worse trajectory, right? So this question, how can they differentiate testing, right? Doing a full thyroid panel, doing a Dutch test, looking at cortisol. I would definitely want to include that in it, because every test I've ran, and I've ran hundreds of Dutch tests, the biggest issue is cortisol. And cortisol is our friend, right? We would die without cortisol, but I see it dysregulated so oftentimes. And that could be maybe the driver behind all of the issues, thyroid issues, sex hormone issues, and the list can go on.
Yeah, it can. And I think it does, looking at the labs becomes really important. I think we have to be, when you look at the adrenal function, I think one of the things that we should mention, because it's a term that gets used too often, and I think it's problematic, but you hear this term tossed around. Well, the reason you have those hormone issues is because you have adrenal fatigue, as if the adrenal gland became too tired to work, and therefore we need to give you the hormones because you have adrenal fatigue. If we really think about how the adrenal physiology works, it is the gland does not fatigue, but it needs resources to work well. And any time that somebody has low sex hormone production or low cortisol production, the first thing we should be looking at is, what is their cholesterol level? Because the cholesterol that's in the bloodstream is primarily which drives hormone production inside and from the adrenal gland. So we can make cortisol, the adrenal gland has the ability to make short-term bursts of cortisol that can maintain like a blood cortisol level, especially when we're checking it first thing in the morning, because there's a natural rise in cortisol. But there's a limitation to how much cholesterol the adrenal gland can make. Most of the cholesterol that the adrenal gland uses to make hormones is brought from the bloodstream. It's not generated within the adrenal cells. So oftentimes when we see people with low cortisol or low estrogen or low testosterone or low progesterone later in life, I often make sure they say, hey, listen, you see that high cholesterol that's in the bloodstream? That is in the bloodstream because you're not getting it out of the bloodstream and into the tissues to either be excreted or made into hormones. You want more sex hormones? You got to have that inside your adrenal gland to start making more sex hormones. And one of the things your body needs to pull that cholesterol out of the bloodstream is the HDL needs to dock to the adrenal gland and dump off the cholesterol. What does it need for the receptors to work? It needs T3 at the adrenal gland. So you take that cholesterol and make it into pregnenolone in the mitochondria of the adrenal gland. What does it need? It needs appropriate T3. So if there's a reduced T4 to T3 conversion in the system, you will have a reduced production of hormones in time. Cholesterol will often be starting to build up. Somebody might say, well, that's why I want to give T3 in these people, because that'll fix it. And it doesn't necessarily do that. Just because you give more T3 doesn't mean it improves the tissue level. I just posted this, I think, on a post of a patient who was on T4, T3 medication, but her cholesterol was, I don't know, sky high, right? LDL is high, HDL is high, cholesterol is high, triglycerides were high, but she's on, I don't know, 15, 20, 25 micrograms of T3 along with some T4. And it was because she's on Armour, right? So I said, listen, if the goal is to try and get your thyroid gland to recover and have better thyroid physiology, I want you to have your doc switch you from Armour and the extra T3 to T4 only. And so we did that, and we got blood work back. And as expected, I got a message when she got her labs like, hey, my T3 is really not very good. I'm like, right, because you don't convert T4 to T3 well. That's the piece I wanted you to understand. And we can now see it and we can monitor it. I said, but what I want you to do is I want you to go up to the lipid panel we ran with it and tell me what you see when we look at the lipids. She's like, yeah, my cholesterol dropped like 60 points, right? My triglycerides are in the normal range. My LDL came down. My HDL is in a better place. And I said, and how do you feel? Do you feel more hypothyroid? Weirdly, no. Like, right. So even though the total T3 and the free T3 were lower than they were when you were taking T3, what that lipid level tells us is that you're actually doing a better job converting the T4 to T3 inside the cells. And now you're doing a better job converting glucose into cellular energy to lower cholesterol. And you're doing a better job of pulling cholesterol out of the bloodstream and supporting the production of hormones than you were when you were on T3. And that was a really good light bulb moment for her. She goes, yeah, but what about the low T3 and the free T3? I said, we'll get there. That will get better in time. But the lesson here is artificially manipulating the blood value wasn't improving your cellular health, which is why she was coming to me to begin with, because she was taking Armor and T3 and trying to kind of figure out how to get there to feel optimal, as well as have her labs look optimal. When her labs looked optimal, she didn't feel well, and the rest of the panel didn't show good tissue status of T3. When she's not optimal based on their practitioner, she actually felt better and had better tissue levels of thyroid hormone, which at the end of the day, I don't really give two craps what T3 or free T3 levels are if somebody's tissue status is good and they feel and function good.
Yes.
If the number's out of somebody's predetermined optimal range, who cares? If everything is working appropriately, that lab values can ebb and flow based on the time, the season, especially thyroid markers. TSH ebbs and flows with the season. TSH ebbs and flows with the time of day that the labs were drawn. TSH ebbs and flows with the medications and how close you are to taking them. So there's too many factors that can influence it and potentially influence T3 as well, that we have to just say, okay, what's the value? How's my patient? What are the story does the rest of the labs determine? And if the rest of the labs and the patient signs and symptoms don't indicate there's a problem, we shouldn't be trying to manipulate a value into our predetermined biased range. I think that's just craziness.
Yeah, I agree. And I love that story. And the whole concept of what's happening at the receptor level, right? And I had a specialist endocrinologist. I asked her what her opinion on cellular hypothyroidism was, and she said it didn't exist. I said, well, I disagree with that. First, that's a bold statement to say, how do you know it doesn't exist? She'd had nothing to back that up with. But to me, it makes total sense, right? And this is something I talk about almost on a daily basis with my patients with respect to any issue that they have. But again, bringing it back to hormones is just because we have a level that is optimal doesn't mean it's doing anything for your body, right? So I'm going to prioritize the individual in front of me above all else. How do they feel? Because not exactly the same story, but along those same lines, someone that we've been tapering down her medication, she still has a thyroid, right? We're working on getting this in this way. I do like the word optimization, right? Getting her nutrients, her sleep, her mindset, in line with better health. And her numbers are not as they went up, right? TSH went up. T3 came down. Free T4 was still around the same. And she felt so much better, which she's like, is this normal? I'm like, well, yeah, because it isn't about the lab. The labs matter, right? I'm going to look at labs. They matter. But if we're looking at them as the be all end all for, is this individual now optimal? We're missing the mark.
Yeah.
Right.
And I think that goes back to what we talked about before. We have to interpret labs, not read them. Right.
Yes.
So if a TSH, let's say, is elevated, but there's low T3, then we might say that elevated TSH is appropriate, right? Given that there's low T3, that may be driving the thyroid gland to make more hormone. if TSH is elevated, and there is lower T4 and T3, that may be appropriate, right? Because there's less, the body's trying to drive more. So a value could be abnormal and appropriate. It could be normal and inappropriate, right? So those are keys. The other thing I wanted to say is I've had that conversation with endocrinologists and MDs, right? And so
Very frustrating.
this isn't a new concept. It's been talked about in the literature for, I don't know, 25, 30 years at this point. It just doesn't get a lot of traction. But two, when somebody says it's about it, we're not worried about the tissue, what's in the tissue. You don't get tissue. I'm like, okay, so what causes hypothyroidism? Is it lack of thyroid hormone in the bloodstream or lack of thyroid hormone in the cell? Right? Because
Yeah, exactly.
doesn't T3 to get the positive effect? Isn't it about how much T3 binds to the receptor? Yes.
Yes.
Okay. Is the receptor in the bloodstream or is the receptor in the cell? It's in the cell. Okay. So then if I have what causes hypothyroid symptoms is decreased T3 in the cell. Yes. Okay. That is cellular or tissue hypothyroidism. And for the clinician could say, but there's plenty of thyroid hormone in the blood. Then the next piece is you say, well, obviously you know that individual cells and tissues have the ability to regulate their own metabolism, right? You are aware of that there's different transport mechanisms, different deiodinases, and different receptors that allow for individual control of tissue metabolism. You are aware of that because otherwise, if there wasn't, then every time your thyroid hormone kicked in and you were running, you'd lose your bowels, right? You'd pee yourself, right? Because everything would kick in at the same time and it doesn't happen. So sometimes you only need to have those conversations, but we just need to lead them to the story. So it's not about what's in the cell. Okay, well then, so what causes hypothyroid symptoms? That simple question. Is it what's in the blood? Is it lack of hormone in the blood or lack of hormone in the cell? Right? Lack in the cell. Okay, then that's tissue hypothyroidism. And they already answered the question. If they say it's about how much is in the blood, well, where are the receptors in the blood that drive the metabolism of the gut or the receptors in the cell? Well, they're in the cell. Okay, well, then I have to get the hormone into the cell, right? Yeah. Well, but I think what some physicians think is that it's all diffusion. But we know that there is some diffusion of thyroid hormone, but a lot of it's active transport.
Yes.
And especially in a situation where there is cell stress and decreased adaptive downregulation of the mitochondria in that cell stress, what's that cell making to begin with? It's making less cellular energy. So if it's making less cellular energy, am I going to be as efficient at transporting thyroid hormone and other molecules into a cell that requires energy? The answer would be no. Right. So sometimes we just have to help people think. And when we help them think, they get to the conclusion on their own. And then they think they're the smart ones. That's
I feel like I'm at a much better place to do that now. At that point in time, this was about my testing and me. So it's hard to see clearly when it's you. And I honestly felt horrible. Right. My thyroid at the time was so enlarged and, dealing with all of these issues. I thought I had cancer, and I didn't have the mind to have that conversation because I was terrified for myself. Right. Now I have a completely different way of approaching things. And I definitely feel very empowered to spread the truth. Right. Because we have to look at what's the latest research, not 30 years ago. What in a textbook, it takes years for it to be what somebody's reading right now. Right. So yeah, that's a topic really fires me up.
Yeah. All right, let's get another one.
All right. Oh, this is a good one. How does insulin resistance or other metabolic disorders influence thyroid health, and what dietary changes can help?
Well, I would say to have glucose or insulin resistance, you must have had some cell stress and decreased T4 to T3 conversion to begin with. Okay. Now, we blame, well, I hear people all the time say, if you've got hypothyroidism, you got to fix your insulin resistance. First of all, the reason they have it, probably because there's a decreased T4 to T3 conversion, because glucose transport in the cell is via what we call glucose transporters. Glucose transporters are T3 dependent. Now, we all know, or not everybody knows, but the one that's associated with insulin is called GLUT4. And that one definitely is talked about in the literature a lot, that it's T3 dependent. You have to have T3 to have appropriate insulin signaling at the cell. And if you have reduced T3, you're going to have reduced insulin sensitivity. I don't like the term insulin resistance because I think it makes insulin to be the bad guy. I prefer to call it glucose resistance because that's truly what it is. It's more glucose resistance than it is insulin resistance. And so that's part one, right? So I think that has to occur to begin with. All the other GLUT receptors are also T3 dependent. Now, they don't all have the same. So you would think, okay, as my T3 is down regulating, I'm going to lose all GLUT receptors at the same level. And that is not the case. GLUT2 is the one that needs the least amount of T3 to be functional. And what does GLUT2 do? GLUT2 is the primary GLUT transporter that pumps glucose out of the liver for very good reasons and pumps excess glucose into the adipose tissue when there's excess, okay? And it works on the lowest level of T3, which is good, right? If I have slow metabolism and I have reduced T3, I still need to do something. I still need glucose in the periphery, and I still need to get it out of there when it's too much, right? So I think anytime you have glucose or insulin resistance, I think somebody needs definitely to be taking a look at your free T3 to free T4 ratio and say, is there a reduction here? Even if the numbers are in somebody's predetermined lab or optimal range. The second thing I think that becomes really important is that we need to be honest when we're thinking about what's going on. We often tell people, well, you eat too much and you don't exercise enough. And that's why you have glucose resistance. Like the cells, the muscle tissues are full of glucose. And if you exercise more, you'll get more glucose into the cell. And I do think activity and exercise is appropriate. However, there are people who are really lean, who never exercise and eat massive quantities of food. If it was just about calories in and calories out, why are they not obese? And there are people who barely eat and are morbidly obese. And so again, they're exercising, but they're overweight or obese. And you'd say, well, I'm barely eating and I'm exercising a lot and I still can't lose weight. The way metabolism is set up, without getting into the complexity of it, as you put more food energy into the body and you start to store excess food energy in the adipose tissue, your body produces a hormone called leptin. There's a lot of other ones that are released, but leptin should go to your brain and say, hey, brain, we're good. Increase the metabolism, wind up that sympathetic nervous system, wind up the T4, T3, make more T4 and T3, because we need to burn off these reserves. That's how metabolism should work. I eat more than I need. I start storing calories. That triggers my metabolism to upregulate. And then when I've burned off some of those reserves, I calm it back down again, right? That helps us maintain a stable body weight. So for anybody to be overweight or obese, part of that mechanism must be compromised, okay, in my opinion. Now, you could say, well, they just eat a ton of crappy food. If they are eating a ton of crappy food, what else are they probably bringing in? A whole bunch of oxidized fats and toxins and other things that are triggering what? The cell stress response, creating inflammation. The inflammation's furthering the cell stress response. So now we're getting down regulation. So I think in almost all those people, they've got a level of underconversion going on due to something. So what should they do? There's lots of supplements on the market to help with glucose dysregulation. You can take berberine and you can do all this other stuff. I don't know if that stuff works for the people that really have health issues going on, as well as we think it should be. Sure, they can work. It can work like metformin. Metformin can work, but really a lot of these drugs are doing is reducing the absorption of glucose into the cells to begin with, into the body to begin with, so there's less available. But I think it really comes back to everything we've talked about, which is 80% of the time, eat healthy whole food, right? Make sure you're getting appropriate amount of calories in, eat appropriate macros for your activity level. I'm a big higher protein person. I think, when I'm working with clients, it's not that I think calories and macros are the end all be all, but I don't think you should ignore them either. And so I like somebody to probably I do a calculation with all my patients based on their activity level, their age, and their T4 to T3 ratio, or T3 to T4 ratio. So based on their metabolism, I alter their caloric intake, their proteins, and I alter their percentage of carbs and fats. But without all that information, as a general rule, I usually say like 40, 30, 30 and work from there. So more 40% protein, 30% carbs, 30% fat. And then from the carbs and fats, which are primarily energy, right? Whatever you feel and function better at, given where you're at currently. Protein, why is it so important? And most people are underdoing protein is because it's the building block for everything. And I think fats are really important because not only are they an energy source, but they're a building block as well. So I think protein and fat should be the key factors. And then we tighter the carbohydrates based on our overall chemistry. And I think if they think about glucose resistance or insulin resistance or prediabetes or diabetes as an immune inflammatory process, there's some type of stress response going on, versus it's an insulin problem. Insulin's just doing its job, right?
Yes.
And so what they should do is do the foundational, work on those foundational factors we talked about, make sure you're getting appropriate calories and macros. And then if those issues, if the issues are still there, then work with somebody to identify what's driving it. Is it gut dysbiosis? Is it infections? Is it disrupted sleep patterns, breathing patterns, and things that you're just not aware of that's driving it? And if you do that, you'll be able to improve your glucose resistance. You'll see your hemoglobin A1C improve. You'll see the amount of insulin it takes to get glucose into a cell reduce. And then the other thing that we have to be aware of, and I'm sure you're aware, is that many times when we do see glucose resistance, we assume it's insulin resistance, but especially in the cases of somebody who has reduced T3 at their pancreas, they may not have appropriate insulin. The issue may be their glucose is elevated, not because they eat too much. The issue may be because they're not able to make sufficient insulin at their pancreas. And that can be another immune condition. It could be a T3, an issue where they're just not getting enough T3 impacting the pancreas. And that's a different situation and a different scenario than the person who's got glucose resistance and higher insulin.
Yeah. And everything is connected, right? It's like this web throughout the body, right? And I do a lot of testing. I'm a fan of testing levels, testing insulin, obviously testing blood sugar. I use CGMs, continuous glucose monitors, a lot. Definitely if somebody has prediabetes, but maybe even in just someone else. I've wore one myself. I was actually in a clinical trial and I saw my blood sugar was all over the map. And I was surprised because I thought I ate so healthy and I exercise all the time. And it was like crazy spikes and then dropping really low in the middle of the night. And so then I ended up wearing one for months. And for me, it was like an eye-opening experience for me to see a calorie. Well, I already knew this, but it solidified it for me. A calorie is not a calorie, right? So many people think like 40, 30, 30, like whatever their macros are. I want to know exactly what are they eating, right? So I use the app Chronometer.
Mhm.
It's free for people to use, and so that I can see what they're eating. And when we change those things, right? So maybe they're eating a lot of protein, but where are they getting it from? Are they getting it from McDonald's, cheeseburgers? Is that the protein source, right? Or is it like a real food instead of the chemicals,
Mhm.
right? And when we get a better understanding for what the body is actually doing, then looking at what is the most appropriate for that person, right? And I know what works best for me is like you, high protein, moderate amount of fat. And I'm not talking about, French fries and bunch of junk oil. I'm talking about like healthy fats, right? I
Mhm.
do a lot of chia seeds, hemp hearts, um, nuts, different kinds of meats, just like the good fats that
Mhm.
the body needs for energy, right? And then looking at, where are my carbs coming from? Are they coming from ultra processed foods? So you said 80-20. And yeah, that's a I think that could be a good place for somebody to start. I might have a little tighter range within reason, because I don't want to sway somebody away from really digging into these factors that can affect our health. But if 20% of the time somebody's just eating candy, which is what I was doing, well, I was actually probably eating it more than 20% of the time, I wasn't going to get the desired result, right? So now I look at, what do I want? Like, what am I in the mood for? And do I really need this right now? And I try to look at the whole picture, right? So if I want something sweet, does it have to be something that's devoid of all nutrients? Right? I'm much more,
And I
not
think that's fine
necessarily.
though, but I think that's fine for where you're at, right? I think the biggest challenge we might to be, I tell people, because I think it's really stressful for people depending on where they are in this
Yes.
process, that they think they have to be perfect, and the drive to be
Yeah.
perfect either stops them from doing anything, or they're living in such food fear that that's creating an excessive response, stress response. So what I tell people is like, look, if in general, I want you to follow what I'm telling you to do. But if you don't do that, and you eat something that's maybe not what we would consider healthy, but you're in a social setting, you're with your friends, it's what's available, and you enjoy the meal and you're happy and you're laughing, it's probably not a big deal. If
Yes.
your body will compensate, right? In a little bit of stress on the GI tract, your body can compensate for that. If you don't feel well when you do that, you're going to learn pretty quickly that it's probably not worth doing it. And most people, when they're doing well and they're eating well, realize when they don't feel good, when they eat those junkier things, or you know what, I had 2 cocktails and I didn't feel good the next day, or I had 4 drinks and I usually don't drink and I had 4 drinks. They're going to go like, I don't feel good when I do that. It disrupts my cycle. It was nice to go out with my friends and do it, but that's not something I want to do. So I would love if everybody was easily at 100%, 95, 100%. But I think sometimes that isn't as realistic for a lot of
Mhm.
the people I talk to. So I try and
Very
tell
true.
them like 80% good habits, 20% bad behavior, and you're probably going to be okay. If you're closer to 20% bad habits and only closer to 80% bad habits and 20% good behavior, you're in trouble, right? And when you ask somebody, like, do you exercise? And they go, well, I try. They means they have an exercise behavior, not an exercise habit, right? When you ask them, do you drink? Well, they have an alcohol, probably more of a habit than a behavior, right? And is that right? Is it wrong? I don't know. But I think we need to, that's the tough part. And I think I learned that's a hard lesson, trying to be everybody. This is how you need to eat. And people were
Mhm.
stressed. And I was creating more stress in their life, trying to make them perfect. And when I started to realize that and started to say, listen, if you don't eat the way it is, or you do something other than what I recommend you do, it's a learning experience for us. So just let me know what you experienced. If you don't have any negative impact from it, that doesn't mean we want you to do it a lot. If you do have negative impact, then we can use it as a learning experience. And I think
I'm
that's
glad you
a good place.
I'm glad you brought up the food fear and perfectionism, because they're definitely real. I see them a lot. And I am not perfect. I tell everybody I work with, I'm far from perfect. It has to do with, at least in my opinion, I'm going to have a little bit more rigidity with myself because of how I feel when I eat this or that, what it does to my body, what it does to the pain in my body, and the way I feel. I have a very solid why I'm on the journey I'm on. So for me, that works. Everybody else that I'm working with, it depends on, first of all, where are they on their journey? What's their why? That's one of the first things I ask somebody when I'm working with them. What do you want your health for? That's really important, right? Because is it to lose 20 pounds? That's what you want your health for? Is it so that you can pick your grandchildren up so that you're not bedridden, right? Whatever it is, if we have a really solid why, then what are some steps that we can take to get you there? How can we bring in more nutrient dense foods, right? I'm probably a little bit more, I don't want to talk too much about percentages necessarily. I mean, yeah, the 40%, 30%, 30%, that's usually where I go with protein, fat, and carbs. But in terms of eat good foods this amount of time, bad foods this amount of time, so much as how can we bring more good things in, like more healthy things that are going to fuel your body, because food is information. And then look at, over the course of time, what somebody is eating in a day and ask them how they feel, right? Have them take notes. I ate McDonald's. How did I feel afterwards? And when somebody starts doing that, light bulbs go off or on, however you would say that. I say go off. That happens all the time. And when that happens, when somebody has that realization, it solidifies the why, then behavior changes are easier, right? And then that becomes like the norm. Like, this is what I do. I'm not exercising sometimes. I'm not eating healthy sometimes. This is how I eat. This is how I move my body, and it becomes who we are.
Yeah. And I think we're essentially saying the same thing. And I think what we're trying to do is accomplish the same things with our clients. And that is, to get them focused on the healthy options versus on maybe what they can't eat or can't do, or what the restrictions are, but also making sure that we're all nobody's perfect. Nobody's perfect. So do the best job, but keep in mind that if your best job is 50%, you're probably not going to get where you want. You got to be doing better than that. And if you have 50%, like I just 50% good habits, 50% bad habits, you're probably not going to get much better than you are.
No.
And so you got to do better than that. If you want to get stronger, and let's say you're a runner and you want to go from running 5Ks to 10Ks, you're going to have to run more, right? You're going to have to do more mileage to get fitter. If you want to have a healthier body, you're going to have to do more healthy things to have a healthy body. I think the old adage is be, do, have, right? You got to be the person you want to be so that you can do the things you want to do, so you can have the things you want to have. We do it the opposite way. We want to have, do, be. Like if I have that, then I'll do the things to make sure I have it. And then, I'll do the thing. I'll do the things to be the person I should be. Now you got to be the person first. I'm going to be a healthy person mindset. I'm going to be a healthy person by doing the habits that create a healthy person. And that's how you get to healthy. But you have to have that as a mentality, and you have to start to have that thought process that this is who I want to be. And if this is who I want to be, these are the things I'm going to have to do that. And then I'll have the things that come along with being a healthy person. So anyway, I think that's good. That was an hour and a half already.
Woo-hoo.
I'm sure maybe we got another 5 or 6 questions answered. So obviously we'll be doing another one because I think you came in with a list of 50. So whether this turns into, we'll just see how it turns out. This may wind up being, 5 of these, maybe it's 10 of these. I don't know. We'll see. We'll try and for the listeners, we'll try and get as many of these questions answered. If there's questions that as you're listening to this that you have, obviously you can reach out to me at office@rejuvegencenter.com and send me what your questions are, and we'll add them to the list. I'll make sure if you know Tara and you're somebody who listens to Tara on a regular basis, or you see her and you have questions, obviously you can reach out to her and add to the list that she has, and we'll try and get as many of these questions answered as possible. All right.
This has been awesome, Eric.
Well, I appreciate you coming on because it's always more fun to do it with somebody else and have that conversation, get different opinions. I don't know if I'm always right. Matter of fact, I would imagine I'm wrong a good portion of the time, but everybody looks at everything through our own bias and our own ignorance. And so that's why it's always good to have somebody else's take. Maybe we agree. Maybe we don't agree. Maybe I learned something from you. Maybe you learned something from me. But that's why we can't always just take like one person's opinion, say that's got to be it. We have to take, we got to listen to a lot of viewpoints and opinions and make the best decision for ourselves.
Perspectives are a wonderful thing.
Yep. All right, we'll sign off. And for the listeners, stay tuned. These are probably going to come out in between the typical twice a month podcast. So these will start coming. You'll see these coming out as bonus episodes each month. All right. So Tara, thanks again for coming on the podcast, and I'll see you next time we do one of these. Okay.
Okay.